Hey guys, now we have reached the last section for cardio. This is the pharmacology section. This is high yield content because many of the drug questions have the potential to include or reference normal physiology. Remember, step 1 is all about integrating things together, so we're definitely going to do that as we make it through this final challenge. Let's go ahead and get started with the drugs for hypertension. Let's not waste any time here and get started with primary hypertension, previously called essential hypertension. Even though the exact pathophysiology of this disease is not completely understood, we can still make a therapeutic regimen by changing the two factors that determine blood pressure. Remember, blood pressure equals cardiac output times systemic vascular resistance. So all of the drugs we're going to talk about change either cardiac output or systemic vascular resistance. Some can have an effect on actually both. So we can decrease cardiac output by giving drugs that change venous tone, causing a decrease in venous return, or the blood return to the heart, aka preload. We can also give drugs that relax vascular smooth muscle tone, leading to a drop in the afterload. We can also directly target smooth muscle cell tone with nitro-vasodilators, or indirectly by giving drugs that inhibit the sympathetic nervous system or the renin-angiotensin-aldosterone system. Okay, so with this in mind, let's work through essential hypertension. It is called essential because essentially no one has really figured out why this occurs. It just does. So the best thought on this so far is that there's unnecessary retention of sodium by the kidneys due to inappropriate neurohormonal renal responses. What do we mean by that? We mean that there's overactivation of the renin-angiotensin-aldosterone system. This leads to excessive vascular tone and excessive retention of sodium. So impaired excretion of sodium by the renal tubules can cause increased pressures due to the retainment of water because water loves to follow sodium. We expand the intravascular volume, this increases the blood pressure. In addition, we can have a situation where also the endothelial cells have sodium channels, and they also have calcium channels. So here are endothelial cells sitting in the vessel. If sodium is in high enough concentration, it can enter the endothelial cells and actually cause an increase in the transmembrane potential that triggers calcium influx. When you increase calcium influx, you also increase the ability of the vascular smooth muscle cells to contract. So again, what does this increase in calcium do? It leads to vascular smooth muscle cell contraction and therefore an increase in the systemic vascular resistance, which sometimes we also call total peripheral resistance. So always think about the equation blood pressure equals the systemic vascular resistance times the cardiac output when you're attacking this disease. So always think about the equation blood pressure equals cardiac output times the total peripheral resistance when you start to attack the different therapeutic regimens. So for example, in primary hypertension, number 1, we give diuretics such as hydrochlorothiazide to block sodium reabsorption. We want to decrease the amount of sodium because we want to decrease the amount of water in the intravascular space. Decreased sodium reabsorption in the renal tubules leads to decreased water retention. Perfect, right? We also want to decrease the effect that sodium has on the endothelial cells that we just discussed. Number 2, we give ACE inhibitors because we want to decrease the activity of the renin-angiotensin-aldosterone system. We can also give angiotensin receptor blockers to decrease angiotensin's 2 vasoconstrictive effects if the person is having a cough secondary to the ACE inhibitors. Number 3, we give calcium channel blockers. Why are calcium channel blockers used? Well, they're used to antagonize vascular smooth muscle cell contraction. We want to decrease vascular smooth muscle tone because we want to drop the total peripheral resistance. All right, so what about hypertension in the situation of heart failure? You approach hypertension with heart failure to alleviate fluid overload. Number 1, we give them diuretics. We decrease the vasoconstrictive effects of angiotensin with an ACE inhibitor or an angiotensin receptor blocker if they cannot tolerate the ACE inhibitor. Number 3, we also give beta blockers, and we give this to patients that have an adequate ejection fraction. If they have decompensated heart failure, which means if their ejection fraction has decreased below 55%, you do not want to give them a beta blocker. Remember, the beta blocker is to also decrease the chronic beta adrenergic stimulation on the heart and the juxtaglomerular apparatus. Remember, super high yield. Do not give this to patients with decompensated heart failure because they need every last bit of beta adrenergic stimulation to maintain whatever cardiac output they have left. So the patients with heart failure also receive something unique. They get aldosterone antagonists. The main one that you need to know is spironolactone. We do this because they have such high levels of aldosterone in their blood. The effects of aldosterone, such as increasing sodium retention, are not good for these patients. Alright, so now we move on to hypertension with diabetes mellitus. Hypertension with diabetes mellitus is really important because so many patients have diabetes, and you can prevent the vasculopathic changes, particularly the damage to the kidneys efferent with an E arteriole. So here's a diagram showing us the endothelium, the intima, and the media of a vessel. Remember, in patients with diabetes mellitus, they have very high levels of glucose. So high levels of glucose leads to non-enzymatic glycation of proteins and lipoproteins. When this happens, we also get these things called advanced end glycation products. We abbreviate this as AGEs. So AGEs bind directly to endothelial cells and limit their ability to function normally. In addition to that, these advanced glycation end products also create reactive oxygen species. All of this leads to inflammation by binding to receptors on monocytes and T cells. So here's our monocyte and here's our T cell. Angiotensin II also contributes to this by reducing perfusion because it causes vasoconstriction, and it can also lead to more inflammation by directly binding to these monocytes and activating them. That's why ACE inhibitors are such a big deal in protecting against diabetic nephropathy. Our main goal is to decrease the vasoconstrictive effects on the efferent arteriole, but also to prevent the pro-inflammatory actions of angiotensin II. Now we also can toss in some calcium channel blockers because this helps relax vascular smooth muscle cells and decrease their tone. Why are vascular smooth muscle cells contracting? Well, because there's endothelial cell damage. Remember, endothelial cells produce nitric oxide, which tells vascular smooth muscle cells to relax. All right, now we move on to hypertension and pregnancy. Managing a hypertensive pregnant patient gives test question writers an opportunity to ask you about potential teratogenic effects of the drugs that you normally give non-pregnant patients. All antihypertensive drugs cross the placenta, so you have to know which ones are safe for the fetus to be exposed to. So the safe ones are hydralazine, beta blockers, methyl-dopa, and calcium channel blockers. So the most often used calcium channel blocker is nifedipine. And the go-to beta blocker is labetalol because it's given IV and it acts very quickly. In addition to that, labetalol also has alpha-1, beta-1, and beta-2 adrenergic antagonist activity, which can help preserve blood flow from the uterine arteries to the placenta the best out of all the beta blockers. This is because the combination of alpha-1 and beta-1 blockade substantially decreases vascular smooth muscle tone, and that's what's determining how much blood the fetus is going to get. Hydralazine is safe to use, but why is it that the pregnant patient would prefer you not to give them that drug? Well, one of the effects of hydralazine is that they're going to increase fluid retention, and pregnant patients are already very volume overloaded. So ideally, give them another drug like methyl-dopa, right? That's the way to go. Remember, methyl-dopa can bind to alpha-2 receptors on the presynaptic membrane. This alpha-2 agonist activity by methyl-dopa will lead to a drop in the release of catecholamines. It is an inhibitory effect on the release of norepinephrine and epinephrine from the presynaptic terminal. This decrease in sympathetic nervous activity is going to drop the patient's blood pressure. Remember, this is for pregnant patients. Now we move on to calcium channel blockers. We're going to see calcium channel blockers twice in this chapter because two of them are also used as antiarrhythmics. So why are some calcium channel blockers used in different situations? This all has to do with calcium channel selectivity. The main difference between the dihydropyridines and the non-dihydropyridines, besides obviously the non at the beginning of the name, is that the dihydropyridines block the calcium channels on vascular smooth muscle cells the best, while the non-dihydropyridines tend to favor calcium channels within the heart. So think back and recall that the L-type or long-acting calcium channel is mainly present in the myocardium and also responsible for pacemaker cell depolarization. So let's talk mechanism of action first. Our non-dihydropyridines, which are verapamil and diltiazem, bind the L voltage-gated calcium channels of the individual myocytes and also the pacemaker cells. Let's check that out here in this image. We saw this image in the physiology section. This is our cardiomyocyte, and on its sarcolemmal membrane, we can see these L-type calcium channels. These are the ones that our calcium channel antagonists that act mainly in the myocardium are going to block. So by decreasing the amount of calcium influx, we're going to drop contractility. There's going to be a decrease in the amount of calcium exposed to the myofilaments. Therefore, there's going to be a drop in intracellular calcium that corresponds to a drop in contractility. Remember, the amount of calcium is directly related to contractility within cardiomyocytes. Now, remember, verapamil is more selective compared to diltiazem for the L-type calcium channels in the myocardium. These guys are also useful for binding the calcium channels that pacemaker cells use for their phase 0 depolarization. Now we can see that here in this diagram. Remember, here we have phase 0. This is the pacemaker potential. If we bind the calcium channels responsible for the upstroke here, this is the calcium current. In phase 0, we're going to drop the rate at which we create and conduct depolarizations. This is why verapamil and diltiazem are also useful in situations in which we want to drop the AV nodal conduction speed. Now, what are those situations that we want to drop AV nodal conduction speed? We're talking about atrial fibrillation and atrial flutter. Why do we want to decrease AV nodal conduction speed in the situations of AFib or atrial flutter? Well, we don't want every single depolarization from the atria being transmitted into the ventricles. Calcium channel blockers help increase the refractoriness of the AV node. All right, now that we shift gears to the dihydropyridine. These guys preferentially block vascular smooth muscle cells compared to the cells in the myocardium and the pacemaker cells. There are two exceptions here, and you have to know them. Those are amlodipine and nifedipine. Amlodipine and nifedipine have equal affinity for both types of calcium channels, vascular smooth muscle and in the myocardium and pacemaker cells. So the dihydropyridines in general, besides amlodipine and nifedipine, are more selective for vascular smooth muscle cells, so their clinical utility is for vascular tone issues, such as hypertension or spasm, and we're talking about spasm in situations such as Prinzmetal or Raynaud phenomenon, or Raynaud syndrome. Now let's apply this to how we use this principle to treat a patient with a subarachnoid hemorrhage. This patient wasn't very lucky and suffered a ruptured cerebral aneurysm. Remember, there are 3 layers covering the brain from outside in. We have the dura, the arachnoid, and the pia. So a subarachnoid hemorrhage means that blood is hemorrhaging into the space below the arachnoid, right here. So blood is very, very caustic. It can irritate the cerebral vessels and cause an increased risk in vasospasm. So what type of calcium channel blocker would you use in this situation? Would you use one like verapamil that has high cardioselectivity? Or would you use one like nimodipine that is very selective for vascular smooth muscle cell calcium channels? Nimodipine is the way to go because we need dihydropyridines. These are the ones that inhibit calcium channels on the vascular smooth muscle cells. We are worried about vasospasm. So in summary, you give the dihydropyridines or non-dihydropyridines for someone in the situation of hypertension because they both drop the blood pressure, but in different ways. Remember the equation, blood pressure equals cardiac output times the total peripheral resistance. Your dihydropyridines will tend to drop blood pressure by arteriolar dilatation, leading to a drop in the total peripheral resistance. The non-dihydropyridines will tend to cause a decrease in cardiac output by decreasing the heart rate and also decreasing contractility. Another high-yield example is the use of clovetapine. Clovetapine is used for hypertensive urgency or emergency. It has a very fast onset and it has a very short half-life. You want to quickly drop these patients' pressures because if you overshoot and give too much, you also want to be able to have the drug quickly metabolized so that you can readjust your dosing regimen. That's why clovetapine is the drug of choice for hypertensive urgency or emergency. The toxicities associated with these drugs are directly related to their mechanisms. So the cardiac depression and AV block caused by our non-dihydropyridines, verapamil and diltiazem, should be rather obvious to us because we're directly blocking the calcium channels that are responsible for the intrinsic depolarization rate of the cells that control the heart rate and the depolarization rate through the AV node. Now the edema, flushing, and the dizziness are all related to the vasodilatation. If you dilate your vessels, you can increase fluid shifting across your vessel wall into the interstitium, leading to edema. The flushing is because you increase the diameter of skin vessels and increase blood flow to the skin. So here's a normal vessel, and we dilate it, and we have an increase in blood flow to the skin surface, and this causes flushing. This makes the person look like a very red cherry. The dizziness is a combination of a drop in the cardiac output and a drop in the total peripheral resistance. This can cause hypoperfusion of the brain, making the person very dizzy. One more thing, constipation. That's a big deal. Patients don't like that, right? So constipation is associated with calcium channel antagonism of the interstitial cells of Cajal. Remember, the interstitial cells of Cajal are responsible for what? They set the baseline depolarization of the intestinal smooth muscle. They determine how much peristalsis is going on within the intestines. This is a rather unique adverse side effect that isn't completely understood. This is gingival hyperplasia. The last one that we're going to talk about is high yield because it lets test question writers bring in some endocrinology. We're talking about hyperprolactinemia. Hyperprolactinemia classically occurs due to verapamil. Now, how in the world does verapamil lead to an increase in prolactin levels? The arcuate nucleus in the hypothalamus has neuroendocrine neurons that produce dopamine, and then they package it into tiny little vesicles, so the release of dopamine from these vesicles is dependent on calcium influx. Verapamil is the bad guy, right? It's going to inhibit this calcium influx. What happens when we do not have enough dopamine to bind and inhibit the lactotropes of the anterior pituitary? Well, the lactotropes are not inhibited from producing prolactin. This leads to a very high level of prolactin, which we call hyperprolactinemia.